So good morning, everyone. We've been using OCT and glaucoma now for over a decade, and I think the role has become quite universal after the initial hitch. And initially, there was a lot of focus on the RNFL, but gradually, we are also now seeing that the GCC is becoming also very important, particularly when we are dealing with early glaucoma. So we all know that structural loss comes before the functional loss, as is seen by many studies. And why should we look at the GCC? Because initial site of injury, is more easily picked up here, since the ganglion cell complex is thickest over here. And so the disease may present elsewhere too as a presenting feature, but the probability here is possibly more. And macular damage is common and it may occur early in glaucoma. The structural loss picked up at the GCC more earlier, like I have already said. And secondly, the retest variability is lesser. The variability at the RNFL is more than at the GCC. So the GCC is particularly useful also for detecting progression earlier. It is also relatively unaffected by structural factors at the disc, like the phenotype of the optic disc. It's less affected by the axial length, and so it's more useful in myopic eyes. However, since the RNFL is where you are able to check 100% of nerve fibers, and at the GCC you may miss out peripheral loss, in the arcuate areas. So you would only pick up the parafoveal changes better. And secondly, the macular pathologies, if they are coexisting, they can really affect the result. So if you're checking the GCC, you must also look at the macular scan and see that there is no associated macular pathology. Always a good idea to look at the larger picture, both in the OCT aspect as well as the patient as a whole, see the whole clinical picture. Never look just at the OCT and make your diagnosis or treatment. So, the study by Hood et al. Has shown that macular GCC defects early in course of disease, more frequent, and are very useful in picking up preperimetric glaucoma, which can be missed if you're doing a standard 24-2 visual field test. And the parameters most useful are the inferior GCC, particularly the inferotemporal GCC. And typically these defects look arcuate, they look similar to your visual fields in the corresponding opposite sector. And the parameter to look out for in the very early stages is a global loss volume, which may be below the level. And a very useful sign in established glaucoma particularly is the presence of the temporal raphe sign. And this is said to be very useful in discriminating glaucomatous and non-glaucomatous optic neuropathy. A study done by Perdici et al. Has shown that if you have an abnormal GCC, very often you have a very good correspondence with a cluster field effect. The field GHT might be showing normal or borderline, but if you have a cluster field effect and you have an associated GCC defect, then the possibility of glaucoma is higher. And so this confirmed the ability of GCC to predict early stage glaucoma before the visual field globe indices are altered. If you have a paracentral, if your GCC macula is affected, you must go for a 10-2 visual field test. There was a study which showed that patients who had normal fields and had an inferotemporal sector arcuate shaped GCC loss, when they were followed up over 6 years, the GCC progression preceded the development of visual field defects in 21.9%, and the visual field progression was seen in 56.9% of patients. So, presence of a GCC thinning is an indication that we should at least be following up the patient more frequently. Also, the focal loss volume, if it is affected at baseline in a pre-perimetric case, then it is a significant predictor of a subsequent visual field conversion. This was seen in the AIGS group. So GLV is an early sign for glaucoma, and FLV would be useful to detect who are going to likely progress. And of course, look at the pattern of the GCC, look at associated optic disc changes, correlate everything, look for even cluster field effects to get a better predictability, you can say. So yes, GCC helps to pick up early. So you see a patient over 6 years who developed field loss, had not followed up in between, and because the fields were normal, we had not started treatment. Myopic eyes are a subset where the GCC is much better than the RNFL because of the associated issues with the optic disc like peripapillary atrophy and tilted discs. And again, here the inferior GCC and GLB have the best diagnostic performance. OCT in general is useful to give us additional information in poor visual field performers. OCT and VFA taken together, of course, give us the best idea of risk assessment. However, the OCT has higher sensitivity, detects within shorter period of time, and the GCC trend analysis was more useful than the RNFL trend analysis in this study. However, there are individual variations, so you have to keep in mind that. And if you're looking at imaging, you have to be very careful of the associated confounding factors, the fact that it can have a lot of false positives or negatives. And of course, look at the effect of aging, look at the effect of cataract. If you've done a cataract, you need to redo the baselines. So yes, it's giving us a key information. We've been generally doing the RNFL GCC scan OptoView along with the visual fields, and we are seeing that there is association of the GCC findings with subsequent field conversions. So thank you very much.
I think it's a very useful adjunct to the detection of early glaucoma, and as she has rightly mentioned, in some cases like glaucoma with myopia, and there will be some cases where there will be some visual field defect. The OCT RNFL may come out to be normal, but there is a corresponding defect in the GCC in the macular region. So I think it's a very useful adjunct, particularly when the same machine can do these tests. There is no reason we should avoid this.